This is Sadhana Alangar, HL7's Director of Education, welcoming you to what promises to be a very informative session. We have with us today a panel of three distinguished speakers. Wayne Kubik is the awesome CTO of HL7 International. Before joining HL7, he was the CTO at CDISC. He has over 25 years of leadership experience in information technology. Swanand Prabhutendolkar is a Senior Vice President for Data Management at CitiusTech. He has over 20 years of experience in regulating, reporting, and standards. Anish Chopra is the President of Care Journey. He served as the first CTO of United States and has written a book on innovative state, how new technologies transform government, giving us all hope for the future. Wayne, I believe you have won the toss to bat. Is that correct?
I'm happy to start things off before turning them over to our other speakers. So can we go to the next slide, please, Swanand? So at today's webinar, we will be covering these key points of what we're trying to achieve. We'll be talking about the, a little bit, it's hard to have a discussion about anything today without starting out with the COVID-19 pandemic. So we will we'll start out with a few words introducing HL7, and we hope you'll see how the criticality of the FHIR-based data exchange.
Wayne, we are getting feedback. Could all the panelists and everybody please mute your microphones, excepting Wayne? Thank you.
I heard that too. So it'll be talking about the importance of FHIR-based APIs and how they can be critical to global health, particularly in the context of the current pandemic. We'll be looking at key regulatory updates and timelines, particularly with regard to the CMS rule, as well as to some extent the ONC rules. We'll talk about a roadmap for IT adoption, a critical need because of the importance of having FHIR APIs. We'll look at several different use cases. And we'll talk about a FHIR implementation guidelines for healthcare organizations. Next slide, please. And I'll take the lead off talking about brief FHIR in general as an enabler. I hope everyone on the call is already well familiar with Health Level 7 International. We've been designing standards for more than 30 years. We have affiliates in more than 50 countries and thousands of volunteers who actually do the work. I am particularly enamored of the HL7's vision of a world in which everyone can securely access and use the right health data when and where they need it. That's something I think that should be resonant with everyone who's experiencing the pandemic in one way or another. And our mission is to make standards available to do those things. The principal HL7 standard you may be familiar with is the V2 standard, which is sort of the basic plumbing for orders and billings within healthcare organizations. The CDA standard, which particularly in the US, but also around the world, is a document standard based on the HL7 V3 framework, which is commonly seen when you visit a provider and they send back a summary of your visit. And then we'll talk about FHIR a little more on the next slide, please. FHIR, which was envisioned particularly from the ground up as a new standard to really address the need to enable global health interoperability. That was the foundation for standard. Graham Grieve, who's the father of HL7 FHIR, has always used this term, which I think says it all, the web for healthcare. What happened with the World Wide Web with the advent of browsers in the early 1990s, the FHIR community is trying to do to use FHIR for the world of healthcare. And rather than go into the details of what FHIR is, essentially it's a technology platform that's based on the same internet technologies we use every day and all the interactions we use, from Twitter to eBay to Amazon purchases. And was designed with a number of different use cases in mind. Today we'll be talking particularly about payers and public health in particular. But you can see from the diagram on the right-hand side, what FHIR provides is an API framework where the right data can be accessed through multiple types of open apps and can be brought to wherever it's necessary in a secure manner in order to address all kinds of healthcare use cases. The idea of FHIR as an enabler, while we've had the vision of it being the engine of interoperability for some years, since Graham developed it almost 8 years ago, I think, is that with the advent of the ONC and CMS final rules as they're implemented, we will now have in place within the USA a national infrastructure that will be built on FHIR APIs and will have FHIR servers available at all major provider organizations. These can support CMS initiatives and value-based care, as well as potential public health issues like disease response and pandemic tracking. The platform really enables multiple applications to use the Smart on FHIR infrastructure with FHIR to rapidly address urgent new use cases that can be quickly put together. But it works very much like the apps you use on your iPhone, that basically you purchase an app and it's kind of plug and play is the idea with the proper authorization credentials in place. You can move data around and you can FHIR supports getting data in multiple directions, as well as presenting data in multiple formats, from data transfers to services, to forms, to documents. And the increased global adoption of FHIR can really help us get to a common platform of collaboration around the world. If there's anything that's, I'm not sure we've ever seen anything quite so globally significant as the current pandemic. And we should all be sharing the FHIR, using FHIR's open source method, the ideas and pieces that we can all put together to sort of solve and address this horrible situation in all countries. But we know we have more to do. The FHIR infrastructure is just the first step in a long process. And we also need to do, to be able to build the types of capabilities and the level of consistency through standardization around the world. But we also recognize that the first step in getting the FHIR APIs out there is not going to magically solve all our problems. It's a process. And we need to take advantage of this infrastructure, build off of it, so we can significantly increase our capabilities to address not just crises like this, but generally to improve the quality, safety, and efficiency of health around the world. Next slide, please. Now, as I said, everything at these days begins with a discussion of the COVID-19 pandemic. And this is an example of some of the things that have been going on within the HL7 world. We, like many, have been trying to direct a lot of our attention, contributed by our volunteers, to try to provide things that can help. Standards can't really solve the problem entirely. They can give an infrastructure, but the reality is that it's hard to put standards in place and then build applications, all of them, in a critical time frame like we're having right now. We want the infrastructure there so that we can build and add on to it very quickly with FHIR supports, just like when you see updates to apps on your phones. But the idea is we need to build up the infrastructure so it can support this type of rapid response capability. There's 4 things that are going on right now. The first one, which was HL7 has worked with Audacious Inquiry on, is the SANER project. And the SANER project was designed to be able to rapidly capture and track the availability of critical resources such as ICU beds and ventilators in response to the pandemic. This will be going under significant testing at the upcoming Connectathon. The implementation guide is already in place and being tested and matured, and we actually feel it will be helping over the summer to begin addressing this problem. The second one, which is right below that on the left-hand side, was developed by the HL7 Switzerland affiliate. This is called the PROM, COVID-19 PROM. And within Switzerland, what they developed was a Smart on FHIR application using FHIR questionnaires that would allow patients at home to evaluate their symptoms and also report back their data to their healthcare provider, or to share it with other providers as necessary, or public health, the equivalent of our CDC, public health institutions. On the right-hand side, there is an application that was the clinical arrivals application, was developed by Graham Grieve and a team in Australia based on FHIR. It's a very simple application. The application was designed to allow patients who are coming to visit a healthcare provider to wait in their cars rather than sitting in a waiting room and potentially be exposed to other patients who might be infected, and basically using SMS to notify them when it's time for them to come in. Very simple application with a very broad range of health capabilities to support social distancing. And the bottom one is a key point in terms of trying to get a handle on representing data in a consistent way related to COVID-19. It's a project begun by Logica, which was formerly known as HSPC, sponsored by Intermountain Healthcare, and it's a collaborative project with Logica and HL7 under joint IP using FHIR. And what it is an implementation guide that defines profiles for the key data elements and terminologies that will be associated with representing data associated with COVID-19. So we have showed they have identified the appropriate link and SNOMED codes that they can use, And it's a way of collecting data and sharing the data and aggregating the data so we can learn what's going on. Next slide, please. Now, within the world of HL7, the recognition that we need to really move faster in a changing world when something like this could happen so suddenly means that we have to really move a little quicker in terms of how we develop standards and how we put together the solutions that we provide. This has been an ongoing initiative within HL7 for some time that I've supported, including simplifying the way the organization works, putting together better tooling and collaboration capabilities within the organization. And we've also set up some particular units to do things. So one of the things we're working on to put in place is the ability to advance the way we ballot and vet solutions through the combination of connectathons and reviews, rather than schedule them only around the 3 ballot cycles we've had historically by working group meetings. We're not having a working group meeting in May because of the pandemic. We should be able to do things just in time when we need them. We set up the FHIR Accelerator Initiative, which was to advance specific use cases. I believe there are 5 of those currently in existence, to bring together a community of interest to work together to rapidly produce and test and mature FHIR implementation guides. 3 of them are listed here. Da Vinci, which was the activity of the project all around value-based care, that has largely a significance for the CMS rule. Karen Alliance also has a rule that has to do with consumer-based access to pay information, also related to CMS. And the Argonaut project was the original accelerator. It was a collaboration of providers and app developers, particularly EHRs, that really started the whole ball rolling with FHIR implementation guides that were built around the US core data for interoperability to provide the core data that can be shared from the rules-based FHIR APIs that are mandated from all provider organizations moving forward. The ONC FAST initiative has been thinking ahead of what can we do to advance FHIR at scale, to increase adoption and to support more effective implementation all around the country. And last things we're working on are bringing the communities together. We've historically had face-to-face connectathons. We're moving virtual now, beginning with one we're having in about 3 weeks on May 13th to 15th. This is the biggest connectathon HL7's ever seen, I think, with 36 different use case tracks that will be explored by hundreds of people around the world. And we also have another event called FHIR Dev Days, which is an event scheduled for June 15th to 18th. It will be an online event with both a mini hackathon each day and 4 hours of really in-depth education functions that are all driven by the global experts for HL7 FHIR around the world. It's really both of these things. We need to build up the community. It's interesting enough that the HL7 implementation community now has over 11,000 people actively involved over our chat stream. And we expect this to happen a lot more as people are more homebound. Particularly, they need to work better collaboratively, and they need to work better around the FHIR capability to really take it some of the places we know it needs to go. Next slide, please. I think at this point, we'll be turning things over to Anish to be picking up the particular focus of this webinar. Anish?
Thank you, Wayne, and I greatly appreciate the phenomenal work that HL7 is doing in an agile fashion, both to respond to the COVID crisis as well to address the broader public policy interests in advancing the health internet, for lack of a better term. Picking up on where you left off, Wayne, I thought I would begin with my take on the current state of affairs with respect to COVID data sharing. And just before I get into slides, to share how exposed we see the failures of our public health infrastructure. And it is an unfortunate circumstance, but we find ourselves $30+ billion investment in EHR records and a broader digitization across the health economy. And yet, when the Centers for Disease Control posted just a week or two ago, of all the publicly reported cases to the health departments around the country, 90% lacked any clinical context for the investigators to understand. We basically are getting phone and faxed in results with maybe an electronic feed on the lab results that person A, even without basic demographics in some cases, like the age or certainly not the race or any other variable, that so-and-so has been tested and has been tested positive or tested negative. This unbelievably sad state of affairs is a call to action, and to connect it to the broader policy agenda on interoperability and the rules on payers and providers. I thought to summarize the status of where we are today as a primacy of a demand signal. What we're witnessing here, Wayne, is that we've got regulated data sets that are publicly available. We've regulated them on the EHR side. We've just announced regulations on the health plan side. And that's the supply side of the equation. Organizations must make data available. We are now entering, I believe, the next phase of our journey where the demand signal runs supreme. And in the case of public health, the demand signal is as clear as night and day. First, we want to make sure that we understand the current clinical composition of all COVID patients in the country, especially on the data assets we've spent the decade investing in. Two, we want to make sure that we have as timely as possible public health reporting. So as we move to the reopening phase of the economy, we can much more rapidly identify individuals for contact tracing and self-quarantining, so we can put out, in the words of some of our public health experts, campfires versus the far more aggressive forest fire that we find ourselves in today. And last but certainly not least, that we have a more thoughtful resource planning infrastructure to understand what surge capacity looks like, whether or not we are in danger of our inability to treat patients with COVID, and that we have much more timely information, not just within an institution, but across regions, so that policymakers can make tough decisions on when to shut down the economy again, or perhaps interventions that are a little bit less intensive, but still minimize some of the damage and the risk. Two initiatives I thought to highlight at the front end of this discussion. Number one, Secretary Azar earlier in the year, maybe month, I should say, years, I mean, far beyond our reminder at this stage, noted that every hospital is obligated to report daily their resources tied to COVID. How many patients are on ICU beds, how many are on ventilators, and the like. Now, as many of you know, that order was met with a big manual burden. Every hospital that I know is calculating this by hand, manually entering it into spreadsheets and sharing as best they can with the federal, the state, the local, the regional, even inside the health system enterprise information. So copies of spreadsheets are flying hither and thither. Thankfully, the CDC is stepping up, and with the help of HL7 and the FHIR community, they are launching a new Smart on FHIR app. It's got the code name Nandina. I am pronouncing it in my Indian style. Perhaps it's got a different name, Nandina. I have no idea, but we'll call it Nandina for now. And it is an automated approach to collecting the necessary elements to feed these resource planning efforts. That is just in alpha mode, but please pay attention to the CDC National Health Surveillance Network Nandina app that will be coming to a neighborhood near you. Similarly, I'm a volunteer advisor to the Chicago Health Department. In April, they issued a groundbreaking order commanding that all healthcare institutions send CCDs as minimum data necessary to understand the clinical composition of the COVID population. There are over 60,000 COVID persons under investigation in the city of Chicago, and 24,000 of them have already had their CCDs shared on account of the order. Now, Wayne, you might point out, while we have standards in theory, on the ground, it is ugly. The inability to extract race from the CCD became a bottleneck, and just the sheer plethora of ways we can diagnose a COVID patient based on LOINC codes. So on the ground reality, Wayne, this has been a challenge. So I thought to share at the front end of this a practical reality of what it takes to kind of use the infrastructure we spent the decade building and applying it in the COVID context. I want to now shift, if you don't mind, on the next slide, on how that relates to the interoperability rules that we are here to spend the bulk of our time discussing. It is obvious to me that we need to marry this demand signal with the supply side regulations that are coming up. And it is this interesting tension between that demand signal and the supply side that I thought might be the first way of interpreting the rules as I see them. Perhaps the most obvious part of the rule is that patients will be given application access to their claims history and to their common clinical information referred to as the USCDI, or the patient summary data out of EHRs. Now, it's interesting in the rulemaking process in that we already have some clinical data available today. We would refer to that as the Apple Health data set, the current common clinical data set. And that is in production and it is continuing to scale. But the new rules flipped the narrative and said that the very first entity that has to go up with their API in the modern FHIR version, R4, is actually the health plan community. And what's amazing about that rule is it suggests that within a year, now in a year and a few months, health plans will have to make their claims data available in a manner consistent with the way CMS does it today via the Medicare Blue Button 2.0 initiative. But, and this is a significant but, if that health plan collects EHR data for HEDIS measure reporting, for care management, or any other purpose, that clinical data acquired by plans must similarly be mapped to FHIR version 4 and available within this first year to applications of a consumer's choice. And if you read the quotes inside the rule, you find a very clear statement that CMS intends the health plan community to be the demand signal for government regulations on providers. Today, the government tells the providers you must have an API, and we're witnessing in this public health moment how poorly we've implemented those standards. By shifting the demand signal from the government to the health plan community, CMS is making an explicit bet that the private sector will create a virtuous cycle of implementation, feedback, and improvement. Quote, "It will be up to each payer's discretion to address whether this information, that is to say the FHIR R4 clinical data, needs to be included in contracts with providers." So for any of you on the phone who are health plans, I presume you are exploring ways in which you can contractually require your providers in the network to provide application access to the same FHIR R4 resources that health providers will have to make available to consumer-facing apps. This is enabled by point number 2. Thankfully, ONC said that not only will we require consumer-facing application access, but we are requiring EHR developers to provide bulk access for population-level analytics. So Health Plan A can tell their roster of patients to Health System B and to access the information from the FHIR R4 server in bulk for that population, both to comply with point number 1, their patient access API requirements, and hopefully to reuse that very same information for quality measurement, care coordination, and all the other use cases that we see critical to a more integrated value-based care delivery system. Critical to this assumption is that ONC allows health systems to decouple their FHIR API gateway, their smart on FHIR layer, from their EHR supplied FHIR server. That is to say, the content to be shared and the method by which you share it can be separate partners. It is my view that every health plan and health provider will default to having their own native control over their FHIR infrastructure that would allow them to negotiate contracts with public health agencies, with health plans, with research institutions, or any other strategic partner in a safe, secure, contractually negotiated manner, the information that links the claims and the clinical data. This bulk requirement and the decoupling of the application access gateway, the API gateway, in my view, holds the keys to the kingdom for what the future healthcare delivery system looks like. And the best place to demonstrate this is CMS. CMS is in production today. Who would have thought a government agency is faster to adoption than the private sector? But yet here we are. CMS has aggregated all of their claims. CMS has modified those claims and upgraded them in a cloud-hosted solution to what they call the BFD, the Beneficiary FHIR Database, and they have made a judgment with their own non-vendor specific application access gateway. So they've enabled consumer apps, and there are over 50 that are approved. They've enabled ACO apps, and over 600 organizations have the ability today to get access to their full populations over the FHIR API. They've just launched a physician-facing model called the data at the point of care, which allows any doctor in America to raise their hands and say, for the patients that I treat on Medicare, please give me their claims history so I can understand the broader care coordination opportunities and gaps in care that I can address. And last but certainly not least, for payer-to-payer use cases, CMS has just announced an alpha project for any private sector health plan that sells standalone Part D prescription drug plans. They now too can apply for an application token so that they can access the Part A and B claims data for the beneficiaries they treat in Part D to meet their 3-star ratings on medication adherence for chronically ill patients. This infrastructure of a FHIR database, the BFD, the Beneficiary FHIR Database, with multiple application access methods, is the architecture we presume health plans and providers will adopt across the country. Next slide. To show you a simple example of this, Rush University Medical Center, if you could go to the next slide, please. This is the Rush University Medical Center CMS Data at the Point of Care app. This is an approved screenshot from our brothers and sisters at Epic. This allows you to see how a doctor in Epic at Rush, and this is of course fake data, but how they can access the Medicare claims history for patients that they're caring for in Epic right at the point of care. And that taps the very same CMS infrastructure we've described. CMS has opened up this marketplace for any application developer to build on all 4 of these use cases. If we go to the next slide, an important problem we're seeing in the COVID crisis is that today's EHR data, the common clinical data set, is insufficient to meet the data requirements for COVID investigations. You heard Wayne talk about the Logica data model for COVID. Thank you, Wayne. Imagine the ability for every EHR to have mapped their source systems into the data model that public health needs to understand the dynamics and the epidemiology of this disease. We are in a moment today where we can now iterate on the mappings that are native in the EHRs. And we're never going to have the holy grail of every data element in every EHR documented accurately by every doctor, nurse, and care manager in the country. That dream of a perfectly uniform database for the country doesn't exist, but we can make strong progress along the way. I refer to this as a Roku moment for healthcare. Tucked in the regulations that have just been approved is a bold experiment that the consumer is entitled to their entire health record via any means the EHR vendor permits. The EHI export clause allows the content and the manner with which that information is shared with consumers. to be developed by the EHR vendors on their own. They may choose to license their intellectual property for their data models. They may choose to make the information available in some kludgy downloading raw text file. It is entirely up to the EHR vendors for the next 3 years to negotiate these agreements with patient-facing applications. My hope is that by the end of the 3 years, we have enough industry consensus on a FHIR-based API option so a consumer can hashtag get everything to all of the data elements, and that the roadmap of what we map in that system iterates with time, like adding channels on your Roku set-top box. Note that I didn't say Apple's set-top box or Amazon's FHIR. This is the open source community set-top box where we can collectively add the public health surveillance channel, the care plan, the imaging data, the cancer information, and on and on and on. We as an industry have the opportunity to shape the narrative over the next 3 years. And I turn to my brother Wayne to stand up the infrastructure at HL7 so that we in an agile way can iterate in adding more content channels on the patient-facing set-top box. Next slide. I end with this broader statement about privacy and security. It is obvious, and I'll hand it over to Swanand shortly, it is obvious that we have to add more tools to protect patient privacy. The regulations do offer some very specific opportunities to strengthen our muscles in protecting the American people. Artfully, the regulators have said that every American has the right to connect an application of their choice, but the data holders, plans, and providers have every right to warn them in the most extreme manner. Many of us know that feeling when you visit a website that you think is safe and the browser tells us, danger, danger, danger. We don't see a trust certificate on this website. That danger icon, we can now apply in the API program. So if there's an app a patient trusts, a health system and a health plan can put this kind of warning sign. In my opinion, as co-chair of the Caring Alliance, I hope those warning signs are tied to whether or not the application is signed the Caring Alliance Code of Conduct, which actually goes beyond HIPAA in protecting patient privacy, even for de-identified use cases. This freedom to put the warning signals in front of an API that's available to a consumer-facing app is the tool, I believe, that we'll use to protect more patient privacy. I'll go to the next slide to wrap and to suggest, if we go, Swanand, just in the interest of time, that I'll just point as reference to our colleagues, the detailed timelines. The rules did say that for health plans that had to meet the January 1, 2021 deadline for all government-sponsored products. That's now been moved to July 1 through a mechanism known as enforcement discretion. The bulk applications for payer-to-payer sharing is moved towards January of 2022. It's actually always been there. And on the ONC side, we've got hospitals that have to report admissions, discharge, and transfer data. That too has been moved out 6 more months to make that a June, kind of a spring 2021 requirement, and about a 3-month delay on some of the other technical pieces that relate to the information blocking rule. Swanand, I think we should skip the next few slides as reference, and I'll hand it to you to discuss the payer implications. So for folks on the line, you're going to see a couple of slides that just give you a little bit more bullet point detail on each of these specific provisions of the rules. Many of you know them from all your existing courses, so you don't need us to repeat, but it's there as a handy dandy reference for payers, and the next slide for providers. And with that, Swanand, we turn it to you to bring us home.
Thanks, Anish. And so I think I'll take another 15 minutes or so, and then we'll have maybe another 8 minutes for the question and answer. So here is what care operations overview is what we were thinking. There are 3 things that that have been talked about in the rule: the member engagement, the provider engagement, and enterprise engagement. That is between payer and payer. First is member engagement. It says that we need to provide a seamless experience to the members, that they are connected either to HR or they're connected. They're getting data from pairs. They're getting data from multiple systems. Using FHIR and okay, in a word which Anish already described some time back, if everybody is exposing data using FHIR, then members should get a seamless experience that I'm able to see my data all over the world, wherever it is, and I'm able to control who is going to look at it and who is not going to look at it. The second one is provider engagement. There have been few gaps in terms of the way provider looks at patient data, payer looks at patient data. Payer would run things like it is on top of it. Provider would run MIPS, MACRA, and things like that. Payer would think these are the gaps in care. Provider would think something else. More or less, they are both looking at the same thing, and maybe there is a little bit of a gap in terms of payer looks at patients' gaps and provider looks at patients' care gaps. And what we were thinking is that this is the time, correct, where the gap of understanding between provider and payer should be bridged. Last one is enterprise engagement, that is between pair to pair. I as a patient move from one place to another, and my data should now be available. So that should be done, seamlessly again. My new pair should be simply able to go back to my earlier one and say, okay, I need Swan's data, and he gets it. That's the way we are thinking. These are the three things are going to be impacted and changed quite a bit. This is a busy slide. I won't be reading through all of this, and this will be made available to you. What is we are thinking how it's going to be. So member engagement, there are so many things that are going to be possible out of it. Provider engagement, you could have so many things that you can do. Provider 360, member 360. You want to do provider benchmarking. You want to do provider encounter histories. You want to do risk adjustment. Enterprise to enterprise engagement. There are so many examples that we can carve out, and we can now make enable using FHIR. But to make all of these gray boxes on the top, those three pillars, available, there are certain enablers that we need, and this is what we thought that we want to talk about. Technology enablers, they're like quality performance. Someone has to figure it out. There has to be identity access management, because who looks at patient's data is now going to be a lot more controlled, and the member is going to control that. FHIR APIs, of course, this is about FHIR, and FHIR APIs are the ones which are going to be called and exposed to data for the data exchange. API management, everybody needs to do. That's again a technology enabler. FHIR testing automation is something pure technical, and Smart and FHIR app framework. Yeah, Anish talked about a lot about Smart and FHIR app framework, and we really feel that this is the time when Smart and FHIR apps can really kickstart their journey. They have been around for quite some time, but now is the time we feel it's going to kickstart. Data enablers, there are many of them. You need to do data integration and streaming, FHIR framework. How do you store it? Converting your data to FHIR model. Various types of data analytics can be made, and yes, ingestion in bulk and FHIR data exchange in bulk. These are the enablers that payer ecosystem will have to now start thinking about, because FHIR is getting mandated, and the data will be exchanged through FHIR resources. Moving on to the next phase, we thought of we'll talk about probably like 2 or 3 key use cases, and first one is about member engagement. So you want to do member engagement, give them a seamless experience. We are talking about first use case, which is notification of inpatient admission. So whenever the patient gets admitted to a hospital, the payer needs to be notified, or the payer currently, if you look at it, it gets notified pretty late in the day, probably when the claims are raised. But just by having a simple workflow wherein there is a prior auth request comes in, the payer then gets the validation, then tells provider, yes, Swanand is now qualified for this particular surgery, you can go with it. They will say, okay, this is the expiry date of discharge. But having said all of that, the most important thing is once when Swanand is actually admitted, a message goes to payer right at the time of admission. and of course at the time of discharge as well. So the moment Swanand is discharged, the message can go directly to the pair, letting pair know that yes, Swanand is now discharged. Data exchange gateway on the pair side should be able to receive all of these FHIR resources that are incoming from the provider side, and telling for pair this is what is happening. The second use case that we thought of is the provider engagement, and there are multiple things that we can do. We can probably give a FHIR app to providers, and what we can do out here is this is one use case that we thought of. As you saw sometime back, there are many use cases that we can actually get into, but this is the one we thought we can talk a little bit more. So provider has a point of care app. Provider gets into his app, looks at the patient, he clicks on the patient's info, and then click one more button, say that fetch gaps. And what the app does is it looks at current data which is there in the EHR, picks it up, sends it to, if the provider has single pair calculation engine being done, it will send it to there. Now the pair organizer receives data, it calculates the gaps the way pair looks at it and sends it to providers. So what we're trying to tell here is pair looks at patient's gaps from probably HIDIS perspective. I'm just taking HIDIS as an argument here. Probably from HIDIS perspective, provider may not know that, and it tells provider, you know what, Swanand has these 4 gaps, and you may want to take care of these gaps as you're treating Swanand. So pair is probably trying to give a heads up to Swanand about the gap that pair is looking at. Giving heads up to the provider about Swanand's care gap that they are looking at, and they would want provider to take care of it, so that pairs star ratings and all other HIDIS score, they are not really disturbed. So that's one way of looking at it. But of course, giving better care is going to be the key here, that the provider gets to know Swanand's history, as the pair would have received maybe few more claims for Swanand, and when Swanand was gone to probably some other health system and not only with this particular provider. Last one we were thinking that is enterprise engagement that we can talk about. That is pretty straightforward. There are 2 pairs who are having each and their own each FHIR gateways, and there are various data that they can exchange. Of course, we know one thing, that is pair can request other pair about 5-year-old history. But they can also talk about few things like medication management, benefit management, and things like that. Because if we are talking about, let's say, coordination of care, I have 3 plans, and maybe I'm covered 80% on one plan and maybe another 20% somewhere else. Then those 2 pairs for one single episode of care for Swanand can still do coordination and data exchange using FHIR. So that's one more use case we really thought can be made possible and can be made easily available. The last thing, how the FHIR adoption and maturity stages. We thought there are FHIR adoption need not really stop at CMS regulatory compliance. It should go beyond that, and that's what we are talking here. The first phase that we are thinking is foundational, that is regulatory compliance, because the regulation has come in, everybody needs to comply with that. The first stage that anybody can attend, we are saying that that's the foundational one, which is the regulatory compliance. Get the technology and data enablers in place, which are going to make you compliant for CMS regulatory rules. The second one is progressive. That is more about scale up and integrate and get more sustainable development goals. Correct. So integration of pair ecosystem. You may have to define certain frameworks internally to do your job much more better than just converting from one way of representing data to FHIR and so on and so forth. And the last one is more of a transformation. That is the one where things like you would probably have a different data model altogether, because now you are exposing data using FHIR, you are getting data as FHIR resources. Real-time data would be coming in. You would want to have some sort of a real-time analytics stuff in place. Bulk FHIR is something which is coming. It is not mandated by next year, but yeah, beyond that would also be coming in. So using FHIR not just for the rule that has come in and just to comply, to the rule, but to actually use it for data exchange in much more effective manner, to exchange data in real time and to provide better care to the patient at point of care is what is the last maturity stage, is what we have been thinking. Coming to the last slide, and this is actually my last slide is going to be, we are actually seeing the earlier slide once again, and we thought about those three steps of FHIR adoption framework. From the ones which are the boxes which are dotted here are the ones which we need to attain, or a pair needs to attain in terms of having the final impact. So encounter history, claim status, and provider directory, these are the three things in terms of member engagement are required from the final rule impact. Provider 360 and patient encounter history, that's something which is required from the paired provider engagement perspective. And enterprise engagement perspective, that is pair-to-pair, the pair data exchange, and the claims management. These are the two use cases that are required from enterprise engagement perspective. So these are the ones which will kind of give you the compliance from the use case perspective. The remaining use cases are the ones which we can keep on adding as and when the maturity level keeps on increasing. At the bottom, you'll find technology enablers. The ones which are in the dark blue are the ones which are foundational. Those are the ones one needs to take care within current year, and maybe by probably by April or May of next year to be compliant with the rule, or starting Jan next year. The ones which are light blue, those are the ones which are we are looking at from a progressive one, wherein we will have a much more parser framework, bulk data ingestion, smart and FHIR app framework, and keep on proliferating more and more apps, or keep on adding more and more functionality to the apps which are already proliferated. That's the way to look at it. And the last one, that is transformation, that is streaming ingestion and FHIR data model, because you really don't want to change or really don't want to migrate to a new data model per se just because a rule has come in. But at some point in time, the data model, the underlying data model, will need to change, because for how long people can keep doing transformations of their data model to FHIR and keep talking to the external world. That is possible to be done for the first few months or maybe a year or so. But at some point in time, the data model, underlying data model, would probably have to be in alignment with FHIR, because that's the one which is going to take over the data exchange business in some ways, and if that's the one in which you are going to receive data. So the best way in future would be to have a data model which may not be exactly the FHIM, but it should be something which is directly in alignment with FHIR data model. And these are the things that we feel, and these are the steps in which we feel, an enterprise can achieve the FHIR maturity, starting from foundational, then progressive, and then transformational. And so many other boxes that you see here, you can obviously read it at your leisure, because this slideware will be made available to you as downloadable one. But those actually boxes talk about what are the different use cases that we feel an enterprise can lit up using FHIR data exchange, keeping FHIR data exchange in mind. And probably now, with everybody exchanging data using FHIR, can be actually made much more natively than it was earlier. Because earlier, if I had to talk to multiple EHR, I have to really get to know the language that EHR speaks. When I say language, I mean the way that EHR speaks. But if everybody is going to talk in FHIR, then getting so many different flavors of apps should not be, rather, is going to be much more easy now. And that's the way we think the future is going to be. Anyway, with this, this is actually my last slide, and we have probably 8 minutes to go. So I think I'll take a pause here, and we can actually go for the questions. Anish, you are up for the questions?
So this is Wayne. I've been monitoring the question box as during the presentation, and probably responding before more than I've been listening to both of you. But I think we can probably, if we can encourage others, there's one, Anish, that I did not respond to from our mutual friend Mark Siegel, which was referring to your Roku slide 13 and saying that the 3-year period he had, he said that didn't seem consistent with his understanding. Could you possibly comment on that?
Yeah, no, it's I mean it's pretty clear. The EHI export provision, in my opinion, that was the provision that was at the heart of the letter that Epic and a number of the Epic health systems had written about, the sensitivity of that data and the, risks associated with how that fuller data set may be used and so forth. The response to that was to make the EHI export requirement a 3-year implementation period, not a 2-year, as the rest of the rule is. And it allows, they created a whole new provision of the final rule called the content and manner clause that was not something that existed in the proposed rule. And the content and manner clause acknowledges that for many EHR developers, the ability to make the entire data set available is tied to their data model, which is proprietary, not FHIR open sourced. And so this content and manner clause allows the developers, EHR developers, to negotiate licensing agreements with apps that are focused on consumer application access. The provision does say that if you can't reach agreement across these 3 years with any app developer, then the burden remains on the EHR developer to, quote, make an alternative manner available. So Wayne, my challenge to you in the course of that conversation was, in the FHIR community, if we could develop a FHIR-based alternative and really drive industry adoption towards that over the next 3 years, maybe at the other end of the rulemaking, we may find an update that says the alternative must be the HL7 #GetEverything option. As you can imagine, I'm going to be lobbying quite heavily for that, but that is not currently a requirement. But Wayne, I will be lobbying you as well to see if we can stand that up.
Well, and as you know, Anish, the way it works in the FHIR community is to basically present a value-based use case and engage the community to work on that. This all began with the Argonaut initiative, as we mentioned earlier, which was, once just the availability of FHIR-based APIs, how could we actually make a consistent base set of data available through FHIR-based APIs that could be used through apps? And so I think you're absolutely right. This is an important issue. I think there's a lot of interest. I think the importance of it has increased with recent events, that it's a great time to build on what we have and engage the community to focus on that. That's how we do things. And by expanding the community and getting more involvement from critical participants and those who might benefit from it, that's how we get things done. That's the power of the FHIR community, and which is in this global engagement. And again, I think now we should be aware of what's so frustrating to many of us is that we see the possibilities. We wish we were farther along than we were, in which case we could do so many more things right now. And we have to really mobilize our efforts to make sure we get to where we need to be before something like this happens again.
I agree.
Of course you do. We discuss this all the time. There's another one here. A question, Anish, also to you. Describe why providers are not able to use EHR systems to provide relevant clinical data on COVID patients to federal agencies. I guess it's addressed to you, but we both can comment on that.
Yeah. So it takes two to tango.
Yeah.
You need an application that is the recipient of said data, and you need a provider capable of sending it. So I'm going to answer this in a little bit of arcana, and I may be a little bit wrong on the details. So let me just get this organized. So number one, today the more common HIE networks, they are scoped to focus on the treatment use case. And so when you issue a query for a CCD on the treatment use case, that presumes the patient's in front of you and you're asking for the data. If it's for any other use case, then there's a gray area as to whether the CCD query gets any response. So if a public health agency issued a query today through the HIE networks, it's not obvious that the contractual agreements that are signed between the networks and the providers, technically the query can be run. The question is the response required or not? That's a sort of a business model challenge. The city of Chicago tackled this by declaring CCDs as minimum data necessary for COVID patient reporting. And as such, deputized Rush University Medical Center with its Epic backbone to serve as a kind of a back end, if you will, to enable these types of queries. So that gave the lawyers more comfort that the CCD is not a nice to have, it's a must have. Now that's jurisdiction by jurisdiction. Chicago declared it. I don't know any other jurisdictions who have, and that would be a critical factor. So that is, in my opinion, the nature of the problem right now. What is minimum data necessary? Who is issuing the query under what authority? And those are non-technical barriers that are in the way.
Right, right. And hopefully we'll see some advances in the policy side to help do that. The infrastructure can support it, but we need the policy. You're absolutely right. I think we're about out of time. Sadhna, is there anything more to be done?
There are a few more questions to be answered. I suppose we can send them the answers later.
Okay, I thought I addressed
Since
them
we're out
all.
of time.
There were
Okay.
several questions asking about the availability of recordings of this webinar. You might want to just comment on that.
Yeah, we have recorded this webinar and a link will be sent to all the registrants and the recording will be available for you for 6 months. Thank you all so much. Thanks to our three presenters, Anishwin and Swanand, for your time. Thanks to all of you for being such an engaged audience. I would like to end this presentation with a quote from the father of FHIR, Graham Greene, who says, "The FHIR logo represents the passion of the community that will change the world. It's a wonderful representation of the passion in our hearts, the determination that we need to do this. We need to make healthcare better." With that, I would like to end the webinar. Thanks, everyone. Stay safe. Bye.
Thank you all. Bye-bye.
Thanks, everybody. Stay safe.
Thank you.
Stay indoors.